Okay. Okay, I'll go ahead and get started. We're recording because somebody might join us virtually who couldn't make it, who got sick, and other people at other interview days are doing virtual. So we'll record this that way they can see it. So I'm Rod Slosser. Thanks for coming and taking the time and effort to travel to MUSC to Charleston for our fellowship interviews. Um, the thing that I want to get across with this intro is diversity and balance of our fellowship. So diversity of cases, the patient population that we see, as well as work-life balance. And so Zach and I really kind of strive to achieve both of those and kind of mentor that. Hopefully you get to enjoy some of Charleston. This is kind of the view I have outside of my office. Dr. Solar has the similar view of the Cooper River Bridge and the peninsula. This is Dr. Solar. This is what he does in his free time. Now, actually, he does a lot of surfing, but I don't think those are South Carolina waves. And then this is me. I'm a little more lame, so we kind of do paddle boarding. This is my wife and I. We have kayaks, paddle boards, so we kind of take the chill way of going. So our fellowship is basically approved by the ARS, the accreditation or whatever you want to call it. We got the 3-year approval, the highest possible, no citations, compliant in all areas. So just to give you some background, so I've been here since 2002, came from UVA and then Penn. This is what I do outside of the hospital. This is my oldest son, Nate. He went to West Point. He's active duty in the Army now. This is my wife when we went to West Point for a football game. And then my younger son, this is when we went up and had family day, right? So you get to climb on tanks and hold guns and do all this other fun stuff. They both played football. I helped coach kind of as they were growing up and even through high school. So that was awesome and a great thing. This is him during COVID, right? So he grows like, he looks like the guy on the rum, like the pirate, you know, like that's what we taught him. So now we have an empty nest. So I kind of just alluded to now, you know, what do we do now that I'm an empty nester? So I do go to Cuba a couple times a year, do mission trips. I've been doing that for the last few years. This is how we started off in Cuba with a little box. This is me doing a DCR. It was terrible. I mean, gosh, it was very painful. And over there, working with a U.S. ophthalmologist, oculoplastic surgeon over here, and we kind of donate equipment and stuff. We've now gotten better equipment as we've gone over the years. So I intend to continue doing that. Zach is our other faculty currently. So Zach came from Oregon, went to Harvard, spent a couple of years there, got his master's in genetics and epidemiology, and has been with us for quite some time, as you can see. This is Zach's wife, his girls during COVID. They don't do this every night, I'm sure, but just during COVID when they're at home learning. And Zach, you know, I don't know how much Dr. Lavity pays him, but he's got a boat, he's got a dock. I can't afford any of that. I have a kayak, right? He's got a boat. He's got his second boat. He just got a new boat. So they go out fishing and stuff. And this is a picture of Zach's new boat. So, you know, it's awesome what, you know, all those balloons do.
Work hard, one day you can be.
We're super excited that we have a third faculty member coming this fall. So in August, Allison, you will join us. So she got her bachelor's MD in residency at University of Southern California. She was a Dean's Research Scholar. She's finishing up her fellowship at Penn. She's going to join us, and she wants to do some research in healthcare disparities. So she's going to get her master's in clinical research for the first couple of years while her clinical practice is growing. And while we can, Zach and I can kind of mentor her and facilitate her getting that, you know, kind of external funding and grant type thing. So I don't think you're going to meet Tina today. I think she usually works from home on Fridays, but Tina's been our clinical trials coordinator ever since Zach started. So she's been with us for like 14 years, I think. So this is Tina and her husband and their baby, their daughter. So Tina does a great job helping to facilitate really like all of our IRBs, coordination with all the clinical research that you'll hear about here. Taryn is our PA. She's been with us for a couple of years now, I think. She does only rhinology. She kind of has a hybrid practice. So she does some clinics on her own, usually Mondays and Fridays at a satellite office. So you won't meet her today, but she also does some of our clinics here at Rutledge Tower with us. So that way she kind of knows our patients. She could facilitate all the phone calls, the prior auth, the pre-cert, all that other kind of stuff to take the burden off the fellow. Patty Humphrey is our nurse coordinator. So Patty does things like, we need to put in, a prior auth on Dupixent or Xantz. She'll get CT scans from outside facilities, things like that. So she is a great help. She has 2 kids. Her son's now in college, so these pictures are a little bit older. Lissa is our nurse that kind of does our day-to-day clinics in Rutledge Tower. There's her husband, a couple daughters who are at college locally. So Lissa has been with us for many years and also does a fantastic job. So Vinay Rathi, who's one of our fellows from a little over a year ago, he kind of wanted to look at what the fellow alumni have done afterwards. So this is a fellowship really geared towards people who want to go into academics. So you can see 85% of our grads go into academics. You see there the distribution of their rank. So a lot of full professors because we've been at this for a while. And there you see the track record of publications. 34 is the median, mean of 81. So pretty productive. And then I'll just kind of go briefly through some of the fellows that you probably have already interviewed with or are going to interview with or heard about. So Sarah Wise was our first fellow. She's at Emory. She's been the president of the ARS. She's had some NIH funding and other grants. Richard Harvey's kind of one of the leading sinus surgeons in the world. He's in Sydney. Been the president of the Australia-New Zealand Rhinologic Society. And some of these research things that I put down here are things that they did while they were here at MUSC. So Richard did some things looking at the sensitivity, specificity of PET CT and skull-based malignancy. A lot of times those patients have crusting, they get a false positive. So we looked at some of that. We looked at some skull-based recon things. Ben Blyer's up at Harvard. He has NIH funding. He's been the chair of the ARS Research Committee. And Ben, when he was here, we did some laser tissue welding, drug-eluting stents, that type of thing. Eric Wong's at Pittsburgh, vice chair. He's been on the board of the ARS, did some kind of clinical outcomes research while he was here with us as well. Alki Saltis is probably the other leading rhinologist in Australia. He came to us from Adelaide, which is PJ Wormold's program, and Alki has taken over that program as PJ's kind of retiring. So Alki did a fellowship in New Zealand, then came to us for a year, did a year here, then went to Stanford. And these are kind of the things that Alki did. He got an AAOA grant, looking at B cells and allergic fungal rhinosinusitis. We did some meta-analyses and other things. David Gudis. So David was a little bit unique. He was doing a PEDS fellowship here, and then decided he liked rhinology, saw the light. So he came and asked us if he could do like a rhinology fellowship, so a second year after his PEDS, because he would always come to our ORs and watch our cases rather than going and, I guess, looking at Strider and other things pediatric people do. So we said yes. So David kind of did a second year. It was a hybrid year because this was outside the match. So we wanted to honor our agreement with our matched fellow. So David kind of was a PEDS attending and did the extra rhinology cases that were going uncovered in extra clinics. He's done an amazing job. He's the chief at Columbia. He's in the ARS. He's been the PEDS rhinology chair. When I was the president, I started a humanitarian initiative that David led and spearheaded. He now does a lot of mission work in Africa as well. So David's fantastic. We still collaborate. We email all the time, collaborate on projects. Jose Matos, also fantastic. So Jose came to us from Pittsburgh. He's at UVA, program director there. Been active in the ARS education DEI committees. We have collaborations with Jose, multiple collaborations with our NIH grants. So they have a PhD named Steve Munger, who's one of the experts in olfaction in the world. So Steve is there doing some things, and we cover the whole spectrum of olfaction, from CRS, biologics, aging, what are outcomes, so all sorts of things that we're working with Jose. We're looking at also a database where surgeons and patients record their outcomes. And that way, We're hoping that with Jose's leadership, that this database can go national so that if you are in private practice, wherever, and you do some rhinology cases, you and your patients can enter the data quickly and easily. And then it will give you basically your benchmarks on how well your patients are doing. And it's going to be kind of confidential. So it might say, okay, like, oh, Alex Duffy, your outcomes are below the national average. And then it'll also say, well, you do fewer, septoplasties, or you don't do turbinates as much, or you do this or that. It'll point out differences. So hopefully you can improve your practice. So it's kind of like a self-help type tool in a way. So it's really a cool idea. Nick Rowan came to us from Pittsburgh and did his fellowship and then went to Hopkins doing great things there. He's the chair of the ARS Resident Fellow Committee. Lots of publications on things like retronasal taste, PTC, septoplasty and CRS metrics. He got a grant from the AAOA looking at AFRS and home mold kits, things like that. So Thomas Edwards is at Emory. He did his residency, came here and went back. So he did things looking at CT volumes and nasal symptoms, eustachian tube dysfunction, things like that. Nikita Chapurin from Vandy. Now he's at Florida on faculty, doing most of their tumor work. I guess they've had some issues with their head and neck division. So he's doing a lot of open and endoscopic tumor work. Nikita's great, fantastic surgeon. He's doing some work with endotypes and surgical outcomes that we did with him, kind of to build upon what he did at Vanderbilt with Justin Turner. Looked at AFRS compliance, race and olfaction type things. Vinay came to us from Harvard. He's now on faculty at Ohio State. Over 100 publications. Vinay was extremely productive with his MBA, and he also had done some consulting work. He's super interested in the FDA regulatory process, also healthcare economics, industry influence, payment models, all those kind of things that most of us probably don't completely understand. And he just cranked out a lot of publications with some of our research fellows. And if you kind of look at some of the stuff we published recently, things on like, biologics and the economics of biologics. What about XHANCE? What about Dymista? And how it's just an eye-opening, some of the work that he's done, like how the people who manufacture Dymista legally blocked generics entering the market. And you're like, oh, okay. And I'm like, wow, I didn't even know all this. So just a lot of stuff like even omalizumab. The price of omalizumab was flat. Oh, then they got approval for polyps, and then it skyrockets. And so just stuff like that you're like, oh man, I didn't realize all this was going on. So Vinay's doing some great work. When he was here, him and his wife Ashley, who's a pediatric otolaryngologist, had their baby, their Southern Belle there. And then Alex came from Jefferson. Alex is going to be the sinus guy at Temple, build the program. And Alex has done a lot of work, COVID anosmia, some biological treatments, things like that. Here he did a QOD and aging project that we'll be presenting at COSM here in a few weeks. And then our incoming fellow is Michelle Yu. She's coming from Columbia, Cornell. She has 12 publications, mostly otology, so we'll try to change that. But yeah, we're excited to have her coming. So, I'm going to kind of go over some of the clinical research projects, and the expectation is really not that you all get involved in every one of these. That's impossible. But if there's something that interests you in a niche that you're doing, also gives you exposure. So like, some of the industry stuff. When Nick went to Hopkins, they were doing zero industry sponsored research, and he kind of built that program. He'd seen how we did it and what you need to do that. And he kind of took that to the next level. So for NIH grants, Zach has for many years worked with Tim Smith as a site and a co-PI on olfactory outcomes in CRS. So that's been going on for like 15 years. And so we still have huge databases of patients and outcomes, validated metrics, et cetera, that we from time to time be like, oh, let's look at this question. Let's look at that question. Zach has a U grant, which is even bigger, looking at biologics and how you decide which biologic to put a patient on, because there's a fairly significant non-responder rate amongst biologics. So if you give somebody let's say Dupixent for 6 months and they don't respond, now you switch them to Nucala for 6 months, and then Now there's new ones coming. So then do you switch them to that one? And it just goes on and on and on. And so really it's kind of a guessing game at this stage. So Zach's grant is designed really to do a deep dive into mechanisms and prognostic factors with that. That's got multiple institutions, and you could talk about it, but it's all over the country. We've got sites that are helping us with that. I have a grant for the last 4 years. We're starting our 5th year, olfactory dysfunction in aging adults. We're getting ready to put in a renewal for that, trying to figure out why does that happen. So we do MRIs, some mucocytokines, some other things. I'm also a co-PI on a trigeminal stimulation in COVID olfactory loss. So there's this PhD in the psych department who invented, I don't know if he invented it. So you stimulate the trigeminal like V1 with a little headband kind of thing. And by stimulating that, we think it promotes neuroplasticity. And so smell training and olfactory recover is probably speeded up. So you don't have to say, do smell training for 6 months and come back. Usually you could say, okay, try it for a month and let's see if it's coming back. So that hopefully will improve olfactory recovery in a whole variety of things. But the whole trigeminal stimulation thing, I think, is really kind of cool and novel, and we'll see where that goes. We're also one of the sites on a CF Foundation grant and looking at CRS outcomes in that group. And then for industry-sponsored studies, it seems like we have more than we can handle. Zach got a grant looking at Dupixent and olfaction, which we've now just finished, kind of looking at mechanisms. How does Dupixent improve olfaction? Are there certain areas of the CT that improve? Is it an airflow issue? Does endoscopy improve? Are there cytokines that improve? All those kinds of things. They just closed a study looking at Theophylline spray for anosmia, which we were one of the main sites for. Optinose, Exient had a study that we've just completed. Insmed is a company that has a different biologic. So all the new biologics, they all need clinical trials. So we participate in a lot of those. We also, I'm working with a company from Israel looking at chemosensory function in the trigeminal, novel ways to measure trigeminal function in the nose. Maybe helps with nasal obstruction, maybe some of our facial pain, migraine type patients. So we've got that we're just getting ready to launch too with a new prototype device in the nose. And then lots of meta-analysis, evidence-based reviews, systematic reviews, those kinds of things. We have an army of students they live next door. I think there's usually like 8 or 10 of them. I think Zach and I mentored 6 this year, 5 or 6. I mean, it was like overwhelming. We'd have meetings like every other Monday. And so they're available, and those students a lot of them are gap year students or they didn't match, and they're trying to beef up their CVs. They come in, they help with our clinical trials, and then in their spare time, they do systematic reviews, meta-analyses, other things, like they reviewed a lot of the CAT scans for Zach's study on Dupixent, measuring the ROIs and what's opacified where. And so they work with the fellows because those students come in and they don't know, like if you're measuring something on a CAT scan, they don't know the anatomy because they're a med student. Or maybe they're not even a med student. Some of them are undergrads trying to get into med school. So the fellow kind of works with them and saying, okay, these are the clinically relevant issues in this topic. And also when it comes to writing, they don't know how to write papers. So the fellow gets to mentor them, and kind of guide them through those processes. And then when it comes time for the final stages, then Zach and I kind of weigh in. But there's plenty of opportunity. Like Dr. Gudis just emailed me like, hey, do you have students to do a systematic review on this topic? I'm like, yeah, we got about 6 of them, pick one. And so we still collaborate with lots of our former fellows to do that. And, Zach and I don't have time to mentor every one of them in every single project. And so it's great to have those relationships. So because of that, we have about 30 to 40 publications per year. I think that you all got the handout probably on kind of what we've done, or you can PubMed us. We have all those research fellows. We're active in the ARS, IFAR. We're both associate editors, AJRA, the board, and European Society as well. We have great relationships with our neurosurgeons. This is them. Alex Vandergrift is the most amazing neurosurgeon I've ever seen. And I've seen a lot of people all around the country. He is amazing. And I don't know if Alex Duffy probably thinks the same. So he's been working with us for many, many years. And then there's a variety of other folks who are doing things, and they're great. It's awesome good to see them doing things in different ways. For example, Dr. Strickland is a younger guy, he's been here, I think, 3 years now. He likes to do the setup, I call it the Pittsburgh way. We're both surgeons staying on the same side and you're kind of all crowded. Well, Dr. Vandergrift does things where we're on the opposite side. So it's good to learn both of those techniques, both of those ways. And then, you see other folks, these are the PEDS people down here as well. So we get called kind of for all of these things. And then just yesterday, here's Alex giving a lecture to the neurosurgery department at their skull-based course. So, and then Dr. Vandergrift is there in the yellow shirt, kind of watching. So there was a cadaver lab that was at Mount Pleasant, which is just across the bridge, where we participated with them. Oculoplastics too, we have a great relationship with them. They call us and email us frequently for any kind of orbital stuff, lacrimal stuff. What about the clinical practice, like if you come here? So about 30 to 40% of our cases are non-inflammatory. So that's CSF leaks and cephaloceles, and we've kind of published on that. I think we have one of the largest series of spontaneous encephaloceles in the world. Pituitaries are kind of run-of-the-mill. And then HHT, Dr. Solar's doing HHT today. He loves it. So pretty simple. Nosebleeds his way, especially when they're on blood thinners. And then the remainder is Revision Fest, Pediatric Fest. We have it's a love-hate relationship with the pediatrics hospital. And I'll show a case that Alex and I recently did there. When you go over there, a lot of times the PEDS ENTs do some of the bread and butter and the easier cases. They're trying to expand that, which is fine. There's more than enough work. But at the same time, the nurses don't always understand what's going on. What equipment do you need? Like all of it. Then we do primary fest with orbital skull base erosion. There's open rhinoplasty and skull base available with those divisions if that's something that you're going to need in your practice or that you want. But you do have to say, well, you can't cover some of the rhinology cases. So it's just kind of, we just base it on the individual needs. I'm putting up Vinay's cases. You can ask Alex about his cases, but it's in the middle of the year and then next week it'll be different. And so I like to say, okay, what can you expect over the year? So this is the last complete year we have, over 400 cases. You see that almost all rhinologic. Inflammatory, I mean, there's quite a few advanced frontal, kind of Lothrop, tree fine type things, a lot of tumors and skull base with, not just leaks and pituitaries, but, intracranial or cancers, tumors, orbital stuff. So a nice diverse spectrum, I think. So I gave this last year, but in 2 weeks, I was like, gosh, Vinay, look at what you've done in 2 weeks. So this was a, frontal osteoma. This is a patient with orbital cellulitis, Wegener's that had needed an orbital decompression. This was a patient who, well, yesterday, Alex did a knife in the orbit with pneumocephalus. This was a car accident with the bling that's on the steering wheel. What do you call it?
Oh, yeah, I have one of those too in the Max, right?
Yeah, Alex had one in the Max. This is one in the
Bedazzle.
intracranial, the bedazzle. That's what it is, the bedazzle stuff. So this is up in the brain. This was a spontaneous encephalocele, and then this was an orbital tumor. This was, I think, another encephalocele. This was gunshot wound, needed a Lothrop, and that doesn't include the regular stuff. So that was like in 2 weeks, kind of what we do. This is Alex's recent pediatric case. He made an awesome video. Ossifying fibroma, we think. So, yeah. Pathology maybe will come back. So you can see that there's erosion of that anterior table into the floor of the frontal, the orbital roof. So we went from below, did a Lothrop, septectomy, because we thought we were going to need to do all that to kind of connect the dots. Here we are going through a little tiny brow where this thing was already pooching through. We had to go through there just to remove that portion of it. And now we're working kind of with scopes through here. Alex had too much coffee. No, it's hard to hold the scope steady when you're not in the nose. So like once you're in and you can steady it. But so here we are curating it out, kind of using a pledget, getting the capsule around the capsule there. And we're trying not to make a big, huge incision, obviously, in the child. So that's the incision. And here we are taking that out. And I don't have sound because Alex gets really excited in the OR. No sound. And then we took it out and we wanted to do an intersinus septectomy. That way, if this thing does grow, as long as there's a way for that frontal to drain to the other side, it would decrease the need to kind of come back and do anything else. So here's our intersinus septectomy to allow kind of a backdoor drainage for that ossifying fibroma. And then we're just getting the last bits off. I think we got all of it, I think. I don't know. I mean, you don't take margins on the skull base for a benign tumor like this, but yeah. So that's the cavity from above with the intersinus septectomy. And then from below, this is, I think, you didn't,
I guess finger in there.
this was me putting my finger in through the brow and Alex looking from below and there's my finger. So had a nice big connection. Then this is kind of some stuff from Nikita, more than just regular pituitaries. So this is kind of, obviously tumor going up into third ventricle. Here's the case. This is with Dr. Vandergrift. And he's great. Him and his residents are great. They don't care how much of the case we do or how much they do. I've taken his residents through like anesthesio resection before. And then a lot of times, Alex just this week doing cases. So this is up into the third ventricle. You see, lateral ventricles there. And then, Duragen. Dr. Vandergrift does kind of a pretty cool PDS plate recon here. So we don't want to shove a bunch of fat or fascia in the ventricle and get hydrocephalus. So we try to do the reconstruction at the level of the sella. And this recon has worked really, really well for us as far as, we don't use lumbar drains. I can't remember the last time we used lumbar drain. And then for a case like this, we definitely would rotate our septal flap up and see that. This is one of Dr. Solar's ambulatory OR cases. So this is just a little, like a mucocele. I mean, it's okay. Patient's got some mental health issues, I'll say, but little mucocele, so just pop into it. So he does a beautiful job with his low throat. So we'll kind of skip through that a little bit. And then there's the beautiful low throat and tidying up. And then, let's just drill into the mucocele. So here's doing it very nice and carefully, way up in the frontal. So you're up above the frontal recess, right? That's the superior aspect of that frontal. And there's just some mucus coming out. And then, what's that clear fluid? I don't know why you put the olive tip suction so far up there. No, there's only been a handful of cases I've ever seen where this kind of thing happens, because we see skull base erosion all the time, right? From AFS and other things. And I don't know, Alex, can you turn one of the lights down?
Yeah, it is.
So that's kind of the mucocele cavity. So now you're in ambulatory, like, oh crap. Okay, now we got to fix a leak. So yeah, there's a little leak there. I should let you narrate this.
Yeah,
Right.
well, so this was a post-traumatic patient, right? So he had prior trauma. And then probably, I think he was obliterated in the past. So then he got a mucocele after, right? So 20 years later, they had these mucoceles. So I think the issue though is that like, normally when you just have a regular mucocele, things are pretty well intact, but I guess in these ones, you have to be thoughtful that you take that dura might be so thin when you decompress the mucocele, just that you can see the dural pulsations just pop the hole. Clearly it wasn't there before because the mucus would be there. But.
So Dr. Solar re-obliterated. So he stripped out all the mucosa he could, re-obliterate. I mean, because you kind of have to do, right? Otherwise, this guy's going to need a big cranie. Then kind of rotating, multi-layer repair. So this will fail in 20 years. I'll be long gone. He'll still be around. Okay. Maybe we'll send him to town.
What was the most important part of this case?
So the patient's got mental health issues, okay? He comes to my clinic for all of his
I
follow-ups.
think I was out of town the next week, so followed up with you, and then he's always followed up.
I've never come back. That's awesome. This is a pretty cool case. Patient had meningioma, you could see not much resected on the outside, but they put in a beautiful titanium plate, and she had this abscess coming through her forehead. So with Dr. Vandergrift, she needed a bicoronal and have the plate out, but now she's got this massive skull base defect. So I raised a septal flap from below and rotated it up. And Alex and I did a case similar to this year. Massive defect, didn't respond to kind of the normal recon. So this is Dr. Vandergrift suturing our septal flap in from above. And it just tells you, look how big the defect is. It's a monster, and there's dead space there. So we sutured the flap in, and you see here's the flap from above. And once we suture that in, from below, that's kind of what it looks like. And then from above, there's the flap sutured in. Looks amazing. And now you got all this dead space. So, lots of like Duragen, dural matrix, a lot of fat, then more fat, then more fat. And this actually worked without a lumbar drain. So we had a similar case. It was a squame this year where Alex Duffy and I did the same thing. Here's fat from below. So we're just trying to do multi-layer recon where we sutured the flap in from above. And so that was pretty cool. I think something to see. There's gauze going in. We're trying to do everything here. So J&A, we do J&As here as well. This is one that we're taking out, kind of two-handed technique. Got a love-hate relationship with the co-blader. Sometimes it doesn't clog. So here we are kind of peeling it out of the sphenoid, mobilizing that kind of posterior part of your septectomy. And you see here kind of the two-surgeon technique, peeling it off the clivus as well. And then you're going to see, we emboed this, but we still clip it because sometimes the embo doesn't work. So there's the artery you see with the onyx in it, black onyx, and there's PPF. So getting around the lateral border of the tumor, and then we'll divide that, deliver it out through the mouth usually because they're too big to come out through the nose. It's the tumor. All good. This is an interesting case. So there's a plastic surgeon that is basically world famous for doing craniofacial stuff and some recon stuff for like breast cancer resections. He did a septoplasty on his nurse's husband for sleep apnea. So you can see that he left the septum intact, but managed to take, the ethmoid roof was certainly causing sleep apnea, right? So why not take both of them out? So this is 6 weeks afterwards when he'd had bilateral rhinorrhea, and the wife nurse said, oh, maybe we should collect this and send it for beta 2. So this is kind of how we repaired that. This is the left side. This is kind of a different game than your spontaneous meningocele, right? Because this is actually brain in a young guy, 30-something-year-old. This is on the right side. And so we kind of basically bipolar some of that, but this is like real brain in a young guy. So you don't want to go too crazy. So we're kind of bipolaring that up a little bit. And then we're just going to put septal flaps over this. You really can't use like an underlay. You could, I guess, but how much brain are you going to take out so that you can have an underlay? We just really wanted to stop the leak and decrease the risk of meningitis. Here we are kind of dissecting on the left side. There's anterior ethmoid artery kind of coming into the field there. And so once we raised bilateral septal flaps, put that up, and then this patient, did well, no lumbar drain. And we'll see there we are using part of the septum to cover our septectomy defect. So tucking that up. He really, that was actually, I was going to make a comment on it because this is him post-op. So sphenoid max there with our septal flap on the left. and septal flap on the right, but you had to put the flap over everything, you know, and yeah, he's not too happy. And he's also asking, how did this happen? Why did this happen? And his wife is in the room, you know, she loves the surgeon she works for. So that was a little bit of a dance too. So this is a kind of a cool case. This is a mass, you know, out in the PPF, but it's kind of got some bony aspect to it. Here you see on the MRI, it's actually bulging through the notch there. Synovial sarcoma of the TMJ. So we did this endoscopically. Here we are kind of working through the septectomy, going through the fat of the PPF. So this is not like a J&A because you got to go through normal anatomy to get to the tumor. So we're here using the Pledget technique to kind of dissect on the capsule. See, there's the capsule. And we're kind of bluntly dissecting around that as much as possible. Now here's a curette. We're like waiting for something to good or bad to happen. Try to push the fat away because that's all normal. We just want to get right on the capsule of that tumor. And then eventually comes out. Obviously kind of 3-hand technique here. And now you get it out. Thankfully, there's not massive hemorrhage going on. Then you kind of look at the bed and say, was there anything else left? So there was a little bit more tumor out there laterally. You could see that, and then we start pushing on the cheek there. But here's getting the rest of the tumor out. So still quite a bit left after that. A big pull. Got it out. So then there's kind of the cavity we're looking at afterwards. So just kind of normal fat out to the TMJ. Here's a, you know, kind of a planum meningioma, relatively standard type case. This is after the resection. You see there the pituitary stalk, chiasm, intercerebrals, and just kind of shows our recon, you know, that Duragen, frequently that we use kind of our first layer. Sometimes we use fat, sometimes we don't. There's a little bit of fat. There's the plate to kind of give you that rigid recon, that kind of gasket seal, which I think kind of makes a difference, at least for what we've seen and for our leak rate, and then a septal flap over all that. But you see how, like with that gasket seal, I mean, that's tucked in there. That's pretty solid. Usually we do a Valsalva at this point, and there's no other leaking, and then we still put the septal flap over that. There's the septal flap. Cholesterol granuloma. Here's a big one kind of pooching into the right sphenoid, and nice anatomy. You see the rescue flaps, septal flap. There's the lesion. You see the carotid, the sella, beautiful anatomy. Kind of drilling into it. The challenge is once you get into it is keeping it open. A lot of times, you know, because there's so much exposed bone. And so there's the cholesterol granuloma. And one thing that we've done that I think works pretty well is we line this cavity with a tubed nasoseptal flap. And so it's a little bit like people using mucosal flaps for Lothrops, you know? And so, you know, we kind of open this up as widely as we can in a safe fashion. And then after you kind of clean that out, there's no leak, which is awesome. You need to irrigate all that stuff out, and trying to get out there with a suction can be pretty difficult. You're inferior to the carotid when you're out there for this. And so then we're going to show our tubed septal flap. kind of tuck that in. So sometimes you kind of have to thin that, make it smaller, put some packing in the middle. This is kind of what the post-op cavity looks like. So you can see right into that petrous apex there. It's nice and open, looking good. This is a brainstem decompression. So these don't come along often, but we do them. They come along. Working with the neurosurgeons, this is with Dr. Vandergrift as well, kind of opening up, everything below the sella. We'll even go up and kind of decompress the sella so that you can kind of move the soft tissue around. These cases are not quick, contrast to the pituitaries. And you're working very deep, so a lot of times the instrumentation is not ideal. And you're also working a lot lower than we normally work because sella's up at the top of the picture there. And then you need to kind of get this all the bone out, completely decompress it. So you see there, a lot of times these have a little bit of a leak, which can be hard to pack off that posterior fossa. But after we do the decompression, some fat, septal flap. You obviously can't put like a plate in or anything like an underlay, and then fat over top. This is the post-op imaging. So good decompression. No lumbar drain, didn't leak. So we're counting our blessings that day. And so you kind of see the pre-op and then post-op imaging here. So what's the fellow schedule? So for you all, it'll probably change because Dr. Yu will be coming on board, and it depends on her practice. She's going to start off slow to get her master's, and things will grow. So it probably will change. But at least right now, Dr. Solar has clinic here on Mondays. I'm at the VA doing surgery. The fellows can come over to the VA if there's like an interesting case or a pituitary or something like that. But in general, I do the VA clinic with the residents and the VA OR with the residents most of the time, and the fellows here. On Tuesdays, it depends, our OR schedule. I don't know how it is at y'all's institution, but like I have like one Tuesday a month, 2 Wednesdays a month, 1 Friday a month in the main. So it's all over the map. So Tuesdays typically are OR. I also have clinic. I frequently run clinic and OR at the same time. This Tuesday, is it this Tuesday? Yeah, this Tuesday, we were running 2 ORs and clinic all at the same time. So a little bit hectic, but that's why we have the fellow, Dr. Duffy. And so then on Wednesday, I have clinic. Again, sometimes I have main OR. Our fellows get attending privileges. So a lot of times they'll also go to the VA to do cases if they want to. Instead of doing my clinic, they're welcome to go to the VA if there's open OR time, and they can get privileges. That's another issue. Thursdays are my ambulatory OR days. We frequently will throw pituitaries on that same time. And, the fellow goes and does the neurosurgery cases, and then I do ambulatory and bounce back and forth. And then Fridays, usually Dr. Solar, like today, he's got cases. Our fellows are attendings. They take attending call. It's the way that the department has, I guess I'll say, transitioned, and you can talk to Alex about it when you interview, is the fellows do weekends. They take 7 to 8 weekends per year. They get extra pay for that. They don't take call during the week. Those are the other attendings that take it. You're, for better or for worse, probably like most programs, you're always on rhinology call. So you get the pituitary apoplex, you get to come in and do that. You get the guy who shoves the knife up in his brain, you get to do that. So, rhinology call is kind of always there. I don't think our call is too bad. Usually the neurosurgeons try to do, like this, the one that came in last night, they're willing to schedule it for 1 o'clock this afternoon, so we can do it when it's convenient. Just you guys will see this. This is our sinus center down on 2. We have 3 exam rooms, a research office, the fellow office. The rooms are actually bigger than they need to be, quite honestly, but it's a nice clinic. We also have satellite clinics that the fellows typically do not go to. Where I go, Taryn goes, Dr. Yu's going to go to a satellite clinic as well. Education, we just had the Southern States at Kiowa, and Alex went down for that. Great opportunity to meet other rhinologists from around the country. David Kennedy came down, to Scala, folks from UNC, Emory, et cetera. We do have resident lectures. The fellows give some of those. Dr. Solar and I give some of those. And so we kind of tag team all of that. Mondays are available, usually research meetings, but we're certainly available for mentorship meetings if there's a question like, here's my contract. Is it a good contract or a bad contract? Because Dr. Solar and I have been through contracts and changes, but the fellows generally have not. And so we can kind of give you advice on that. And then the opportunity to mentor the research fellows. We expect fellows to come in and be able to perform ethmoid maxillary sphenoid surgery for the most part. I mean, obviously, we're all going to have different nuances, different techniques, but we want our residents to do that. We want the fellows to teach the residents how to do that. Learn how to do, frontal and skull-based surgery the way we do it, and certainly happy to incorporate training that you guys have had. If you want to write a grant, we're happy to mentor you that. You can see a number of our folks have gotten AOA grants. Typically, you got to say what kind of grant are you going to get? Because the core grants through the academy are very, very difficult to get because you have to apply for them in January of your chief year. You're not at the institution. You're going to be during your fellowship. So it's just really hard to do. So the AOA has a nice mechanism where, you write a short grant, you can get funding, $7,500, and then you do some stuff. If you want to write a bigger grant, like Jose's writing this multi-institutional thing, Zach and I have mentored him on that, even though he's a faculty member now at UVA. And then kind of at least a national presentation, publications, that type of thing, and assist the residents at OR clinic and assist the sinus course. So we welcome when the fellows bring in new ideas. I always like to hear, what did you do during your training? So our program, as you may notice, Dr. Solar did not do his fellowship here. That's very intentional. I know a lot of programs, they hire their own. We don't want to do that because I'm very thankful that Dr. Solar does things differently than I do. And so the fellows get exposed to different ways of doing it. I trained at Penn where Dr. Yu's coming from, but that was over 20 years ago. So they do things very differently now. And so that'll be awesome. She'll bring in new ideas, new techniques. The fellows will get that exposure as opposed to everybody doing it the way that the senior person does it, which I'm not a huge fan of. So we really try to tailor the needs of the fellowship to the needs of the individual, where you're going, what your research interests are, your clinical interests. We think the fellows become well-rounded rhinology leaders. We want to have that collaboration around the world, even after the fellowship, and gain independence as the year progresses. You could talk to Alex about independence. He's doing rooms by himself, and that's all good. And then, diverse case mix and a balance, research balance, work-life balance. This is, so just to make sure everybody's clear, I'm the guy with the white shirt over there covering up my upper body. Dr. Duffy is over here. I was going to take a picture of Alex standing up on the surfboard catching a wave, but I couldn't. There was
like a half moment.
It was like Bigfoot. Like, where is it? Where's Alex standing up on the
It's a
board?
lot harder than it looks, guys.
Dr. Solar surfs on boards half this size because he's really, really good. But yeah, so this is at the sinus course that we just finished and had a really good time. So with that, I will conclude, and let me see if I can stop recording. Oh, I wonder if I hope I got that recorded. Yeah, stop recording. Okay.